All right. So Eric, would like you to talk about your experience, and then we'll probably have a little time for questions before lunch, and we'll kind of talk you through what we hope you can work on during the lunch and have some fun with.
Thanks. So I talked about who I am, Eric Van Houten. I'm the CEO for the Community Health Centers of Lane County. A little bit about myself. I'm a reformed clinician, now in administration. So I went over to the dark side for you clinicians, and for the you administrators, I saw the light. And I've been involved in integrated care when I didn't really know what I was doing as a clinician, and then I had an opportunity to receive a training from Kirk back in, I think, 2004, 2005, right around the time that we were working on launching, we'd hired somebody at our clinic. But, and so it's been an interesting, I'd call it a roller coaster ride, and I'll talk more about that. My organization, so we're a community health center down in Eugene, Springfield area. We have 4 sites, 2 main clinics where we have 8 providers between pediatric and adult medicine, and then we have 2 satellite clinics. We are part of the county infrastructure. So what that brings with us is all the joys of being in county and all the challenges that comes along with being in a big bureaucracy that doesn't really know healthcare but thinks they do. And then we also are sisters to a behavioral health, a community mental health program that played a big part in our initiating services. So that's a little bit about our clinics. We serve about 25,000 patients. And we have 18 primary care and adult providers between part-time and full-time, and then we have 3 behavioral health specialists or consultants. You'll hear, and I think a lot of us, walking around, it was great to see that a lot of you have quite a bit of experience, and I'm going to pick on Providence in the back, and specifically Vanessa, and I'll talk more about Learning Collaborative, but that their organization is in, that's similar to ours here in a second. But they're far down the path, and I said to her, you're not going to learn anything from my 20 minutes. But they're doing wonderful things at Providence, so it's an opportunity in the room of a peer who is doing really amazing things. But back to what we've been doing. So in 2005, we were a fairly new community health center. We'd only been launched in 2004. And it was a response to the need for the uninsured and underinsured patients in Lane County. Very quickly, as we launched with about 4 or 5 clinicians, a couple docs, and then made up with nurse practitioners, mainly adults, high chronic pain needs and demands, narcotic needs, and a huge number of mental health and substance abusing individuals. Quickly, the providers got overwhelmed, identified the need for a behaviorist. I was involved with some of that conversation because at that time I was actually at a nonprofit, and that's where I had cut my teeth on integration, was at a local nonprofit. And so we were involved in helping identify what is the best need and way to serve this really high needs population. So we identified that having a behaviorist is the best first step, identified the need for one single record, not the dual records that often was happening at that time. We couldn't figure out, or it was hard to figure out at that point, how to get reimbursed for this service. So there's identification of let's not bill to begin with, because we're not sure that we're walking in areas that we really can bill on the mental health side, or can we get reimbursed for this on the physical health side. And we went to the community to try to get some people to come over and provide this service, and they all looked at us and said, "You're flipping crazy. You can't do this in primary care. You have to refer them to us, and they will screen them, and we'll determine whether they're appropriate for our services. And by the way, they need to go on a waiting list. And by the way, that you can only call between 10 and 12 to get them in. And by the way, they have to, and by the way, and by the way." And our primary care provider said, "Screw it." So a theme that you'll hear around is our community was not ready. So we hired our own. Somebody came over from Bend. She had a background in chronic pain. She was an LCSW, and she was fabulous, Tony Berube, and we really launched it without all the services initially that Kirk and his team brought to us, and we did the same exercise that you just did. Minor variations, but the same exercise. So we've grown since 2005. As I described, how big our clinics are now. At that time, we were one clinic, about 6 providers, and then 3 satellite clinics that had just small, single-placed providers. So we've grown significantly since then. At that time, there was about 7,000 patients in our panels, and now we have 25,000, as I mentioned. So we grew in our readiness, and I'm going to talk about it from just an organizational, administrative standpoint, and then also talk about it from a clinical standpoint. So organizationally, we put together a strategic plan. It was one of our main goals within our strategic plan to have a fully fleshed out integrated behavioral health. That's our phraseology. Integrated behavioral health plan with goals that we'd have a provider attached to teams, and they'd be able to alleviate some of the stress of mental health and substance abuse on primary care, including pediatrics. We wanted to increase our knowledge. We recognized that what Kirk had provided to us was fabulous and it was excellent, but we needed to continue to learn and grow and learn and grow, because I would say you're never done. It's like those of us who are working towards patient-centered medical home. I don't know, you get identified by the state as Tier 3, but your work is never done. You're continuing to work to become more efficient and a better provider. We also had an expectation that we wanted to get reimbursed for this care, believe it or not. So we wanted to be able to bill specifically Medicaid or Medicare for this. And we also wanted to bill on both sides of the house, as it were. We wanted to get reimbursed from a mental health standpoint, and we wanted to get reimbursed from a physical health standpoint. And we also recognize the need for training, as Kirk mentioned, and I was talking to one of the clinics over here a minute ago. We identified that we needed to make sure that the training started with the front desk, because that's where, actually, and on the phone before that, most of that initial conversations, right, we all know this, gives the flavor for the rest of their experience. If they have a negative experience with the front desk person, if they're not attuned to what their needs are or what's going on for the patient, it's going to turn into something, it's going to change the experience for the RN or for the MD. So we wanted to make sure that we had a full training component. And including high-end administration. We didn't want to stop at just the clinicians. We also really were very clear that we wanted one chart. We didn't want to have separate charts, and we've done our best to do that, I will say. For those of you who are familiar with the mental health side, we still have to have a separate part within the chart that meets mental health AMH guidelines, or Oregon Health Authority, but AMH guidelines. And we wanted a fully fleshed out EMR that would allow us to do both. That had a seamless flow between primary care and behavioral health care. And we wanted it ultimately to work for our community mental health program. I'll get to where we are in just a second. We recognize the need for patient satisfaction surveys, and that was an important goal for us, that have the patients to have a voice in how are they experiencing this. We have an idea of how this is working better. Providers able to see people more quickly. When they do have a stressful event, they hand that patient off to somebody else. But we wanted to make sure that patients were having a positive experience about that. So we put a patient satisfaction survey together. And then in addition to that, we wanted to make sure that providers actually were getting out of it what we had hoped they would be getting out of it, feeling like they were supported, that they had enough information, they had enough support in managing people with mental health and substance abuse issues. So we did that as well. And part of it, I think it goes without saying, and I'll talk about it here in a second, is we wanted it to be beyond co-located. A lot of times we talk about that's the end game, is we want to co-locate people together. But actually, that doesn't mean integration. Integration is you're fully entrenched together. You see this as a joint team, and you are both on the same team in terms of serving this patient. So those were all of our sort of administrative expectations and goals. When we started, we didn't really see that we wanted to change clinically a whole lot. We didn't want to define who's the right person and who's not the right person, because that was to be referred to integrated behavioral health, because that was an emphasis of our provider champion at that time. Her perspective was, I don't want to have to figure out if, this diagnosis is right. That's what I had to do with community mental health based programs, where I had to identify this diagnosis fits, this one doesn't. I want to be able to say, this person, I don't know what's going on. It's not medical, or it's kind of medical, but there's something else going on, and I need to get out of the room. So I don't want to have to figure out that you're a diagnosis, you have a depression diagnosis, or you have an anxiety diagnosis. I could if I had to, but I want to keep going. So we didn't initially target clinical outcomes. We did later, but we didn't initially. But what we did look at with our initial targets as we moved forward from 2005 through 2008, 2009, 10, et cetera, is we recognized we really needed to rebuild that bridge with community mental health programs. We were trying to do too much in-house, and we needed to rebuild that component, whether it's through psychiatric consultations, whether it's through referrals for case management, et cetera. That what we designed, which was brief solution-focused therapy, supportive in the moment, in the exam room, assessment and triage, but we recognized we couldn't do case management, and we didn't want to do case management, so we needed to refer that out. And when I say case management, I'm talking about housing, money management, referrals beyond just that first primary care need. Does that make sense to everyone? So we needed a better relationship with the community mental health programs. We also needed more than one identified provider champion. As we grew, we needed more people in the table, more people trained, and more people knowledgeable about what does it mean to be running an integrated behavioral health clinic in our primary care clinic. And we did that as well. And we, as I said, we went from about 4,000 all the way to a 25,000 patient panel. So we added another main clinic, which significantly changed the dynamics. And what that grew in terms of our behavioral health team was we grew up to 746 contacts in 2011, which was a sizable number, and we've grown that by about 10% since then. I'm going to talk about an error that we made. Actually, I'll come back to that. One of the things we did so when we finally got it together and we said, okay, what are our clinical goals? What do we want to have as an outcome for this? Is we looked at the PHQ-9 scores. Some people are pretty familiar with these as a measure of at least looking at depression. We know that doesn't cover the full spectrum, but it's a good tool to look at a spectrum and finding reduction in that. So we started with looking at their initial scores when they come in, and then anyone who has a mental health diagnosis or on their problem list, as well as anyone who's on an antidepressant. We do it every time they come in, we do a PHQ-9 score. And then people who are actively engaged in brief solution-focused therapy will do one on a monthly basis. And so we're looking for a reduction of 5 to 10 points as a clinical outcome. We're also targeting reduction in emergency department utilization as our other clinical goal. So that's how we grew in a readiness. If you look at, or if you listen to me well and you look at the readiness checklist, I touched most areas. I didn't talk so much about our overall organization. We're under the Health and Human Services guidance from Lane County, and they are as much bought in as any organization that I've ever encountered. On top of that, they put integration as one of their main goals in 2012. So they took the work that we've been doing in the clinics and brought it to the whole Health and Human Services department. Where we are now, well, in 2011, we changed tactics from when we first hired a behaviorist, and we hired 2 psychiatric nurse practitioners. I'm checking on my time, so I got about 5 minutes. We hired 2 psychiatric nurse practitioners and 2 behaviorists. Didn't work. Anybody want to venture why it didn't work? It wasn't expense. It was too expensive was a guess. That was one. Internally, we weren't ready. All of our primary care PCPs said, oh, here you go. here's this problematic patient, here's my chronic pain seeker, here's my probably got an access to issue going on and using substances, here you go, and they got dumped on. And they both felt like, oh my God, this is way beyond my capacity. What's the second idea, which you probably won't get, so I'll just say what it is. The community wasn't ready for it. I put a stipulation out that they could only serve our existing patient panel. We didn't want the whole community referring everybody to psychiatric nurse practitioners in our primary care clinic. And so we had a phrase for that. You know, you have to be an established patient to come in for this visit. Pretty soon we had referral sources saying, we know that you have to establish care before you can come in to see the psychiatric nurse practitioners, so they want to establish care to see the psychiatric nurse practitioner. So our community wasn't ready for it. And when I say what's important about this, as you look at your community and organization, which I know is one of the core competencies, one of the core readiness checklists, is you really have to dig pretty deeply to figure out how ready are we going to be for this? Is our community going to be ready for this as well as our team? So we have scaled back to just having 3.25 behaviorists. And I'd have to say, all are much happier than the 2 psych nurse practitioners who are trying to resolve the world's problems. I mentioned our department-wide goal around integration. We're financially solid. Our expectation is that there's 9 patient contacts per day, 6 of them in warm handoffs. My staff affectionately call them WHOs. Have you guys heard that one before? WHOs, warm hand offs. WHOs. So they're averaging that and more. We do a quarterly training with staff, and that's all staff, and it can be on a variety of different topics that are mental health or substance abuse related. We're working towards, one of our clinics is working towards becoming trauma-informed practice, which means being aware, for those of you who are not on the mental health side, being aware of all the sort of dynamics of your clinic that might be less than welcoming to someone who is a trauma survivor. Little things like, you know, how do your lines, your check-in counter line up? How close is the person behind them to the next person in there? If a person gets stressed, are there 2 exits out of your waiting room or 1? What do you do when somebody starts to escalate? What's the response? Is it the biggest guy in the clinic comes in? Sorry, not to be gender biased, but that's what happens. What do you do when someone, so those are the kind of things that we are considering. What's the signage like? What's the environment like? How might somebody approach being approached? You know, do they ask a question? If they want to engage with somebody, but before they touch them, do they ask about touching them first? Little things like that you think, well, of course we do that. Well, do we have to do that? Well, not with everyone, but someone who's got a trauma background is going to be more responsive to that than others. So those are some things that we're working on. And then the last thing I want to mention is just the learning collaborative and the trainings that we did in terms of expanding our knowledge. So in 2010, we joined Providence and about 4 other, Vanessa, is there 4 other groups involved? With Intermountain Healthcare out of Utah, and there's a learning collaborative that we are part of around mental health integration. And really, it's a wonderful, full, broad spectrum look at integration and all the pieces that go into it. And as I said, Providence is with us. We're the 2 Oregon clinics. And then there's a clinic from Utah, somebody from Mississippi, Massachusetts. And it's a wonderful learning collaborative to kind of weed through the challenges that we face as very disparate clinics, but all of us working towards mental health integration. The other thing that we sent staff to is training from Cherokee Health Systems in Tennessee. So when somebody said evidence-based, you know, these are both organizations, Intermountain and Cherokee, who've been doing training and integration for a very long time, and they're a great resource to expand our knowledge base. So that's where we have started, where we have moved towards, and where we are at. And I have about 10 minutes for questions. I covered a lot of things there. Yes?
Could you speak more on the financial part of it? How do you
How do we make money?
Yeah. How does it work financially in the clinic?
So we're an FQHC, so we have the benefit of what's called cost-based reimbursement. But we're also part of our community mental health program. We are an aligned entity, so we can operate under their license. So that's one piece. So we can get both sides of our services paid for. The other thing is everybody serves Medicaid in this arena, right? Everybody's CCO should be have their health and behavior codes turned on. If they haven't, they need to talk to Oregon Health Authority about working with them to get those turned on, because that's a reimbursement model as well. It's not paid for as much as it should, but there is a model of reimbursement that way. Vanessa's team uses those codes solely, if I understand correctly, in Providence. So those are we have two funding streams in that way. And then the third one I'd say is, as Kirk mentioned, there's about a 10 to 12% increase for primary care when you have an integrated behaviorist in the fold, and that's an absolute truth. That if you have that behaviorist, for example, we had a woman who was fleeing domestic violence on Friday. Her and her partner happened to be in the clinic as well. Instead of the primary care physician sitting with that woman or the nurse or the MA, who would take them out of their normal roles, we had an integrated behavioral health person there to support that person through that, and we were able to continue to move the clinic along and seeing patients. That would have shut the clinic down. So those are the three prime mechanisms that I would describe to in terms of getting reimbursed for it. Yes?
So with that girl that you're just talking about, where does her mental health services come in? Do you refer on for more in-depth therapy?
Good
Because
question.
you can't really accomplish you can accomplish a lot in 30 minutes, but those clients that are longer term clients, what do you do with?
For all the behavioral health people in the room, we didn't just spend 30 minutes with her. We spent much longer than that. But, it's really a determination by our behaviorists. They have three options. They can do just be here in the room with you and then continue to support you every time you come back for just your normal primary care visit. And you can be there every time. And sometimes that's a patient decision, and sometimes that's a joint decision between the patient and the integrated behavioral health provider. So that's one option. Two option is, yes, refer out to the community. If they have a pre-existing relationship with a good community mental health provider, we'll always try to get them back connected to them. The third one is 6 to 10 brief solution-focused therapy sessions. Yes, this woman who is, in a, she has been traumatized. She's fleeing. We got her connected to a healthcare provider, a mental health provider who also provided her shelter, et cetera, women's center. Yes.
So she's my nurse practitioner and I'm a mental health therapist. And right now we're kind of separated, but kind of together, how we work. So I'm just kind of curious on, could this scenario work in our clinic where I do see kiddos for longer, 20 sessions sometimes. So how can you make it work with just the two of us? Does
Yes.
that make sense? How could we frame that?
So two things. One of them is we identified in a mental health, in a CHC, which generally serves a higher percentage of mental health and substance abusing population. We identified that we needed about 1.0 FTE per 3 provider FTE. I'm not sure what Providence's is. It's about that same. Intermountain, for example, in Utah is much higher than that. So a 1-to-1 dyad around this is wonderful for you as the nurse practitioner, and I think it would allow you to have, my guess, they're the experts, but my guess, it would allow you to have that opportunity to have longer-term relationships because the demand for you is not going to be as much. When you've got 1.0 FTE to 3, you really need to be there available for those warm handoffs and those crisis-oriented solution in the exam room. 2/3 of what we do is just in the exam room and never comes back to a mental health service delivery. It's just in the exam room. Yes?
Did you mention, do you have a consultant that as well? or do those two, the social worker, your behavioral function as a consultant?
So they operate, good question, they operate as the initial consultant. So they basically, what they do now is they weed out sort of those personality disordered folks and or folks who have a substance abuse issue, who would not be a great consult with a psychiatrist because they want to establish that those are not part of the diagnosis. So they weed those two things out. And then we now have, as I said, we were working on reestablishing relationship with the mental health, community mental health provider, and we've done a better job of that. And so now they're feeling like, oh, you're not just sending me everybody, you're sending me specific people who make sense.
So do
Yes.
they manage the statistics, the outcomes, do they kind of work on the data part, like some of the consultant work that I hear would be useful?
So it's a combination of administrative staff who support our integrated behavioral health consultants. So they do it together. They have some support to do that. Yeah. Yes, sir. Last one.
I'm just going to set up the lunch.
Okay.
Have you achieved some of your benchmarks? And have you seen a
Yes.
reduction in ER visits? And are they mental health ER visits or are they overall ER visits?
Thank you for that. We haven't achieved that because we just got that data from our CCO just recently for 2012, 2013. So that's a goal for 2014. So we have not, that is one we just established. So we haven't achieved that. And the other couple ones we absolutely have in terms of a provision of services, where we have this formula of how many providers we have per IBH providers, as well as beginning to track PHQ-9 scores. We're seeing a trend that we're hitting our metrics around PHQ-9 scores. And depression in Lane County, at least, and I know it's a little foggier down here than the rest of the valley, or down there, is the highest diagnosis across the CCO. So if you look at behavioral health, primary care, it is the highest diagnosis, highest single most diagnosed disorder. So we have some successes, but I will say, you know, this process never ends. Intermountain would say it never ends. You constantly have to pay attention to it to have success with it. You know, once you launch this, you won't be done.
Thanks. Great job. Okay, you have on the right-hand side of your folders a list of questions, and what we'd like you to do is to arrange yourself during lunch to sit with people from your discipline. So if you're behavioral health providers, you'll eat lunch with behavioral health providers. If you're more operational type folks, eat with operational type folks. And then if you're primary care clinicians, you'll eat together. Now, Eric will be floating around talking with, you know, clinic management kind of staff. Kirk will be your go-to guy if you're a primary care clinician and you have these discussions about these questions. And then I'll be floating around talking to the behavioral health folks. The list of questions include, do you believe that implementation of this model will improve health in your community? How? What are the barriers to implementing this model at this time? And do you have ideas about how to address those barriers? And then 3, what is unclear to you about this model at this point? And what questions do you want our experts to address after lunch? So the 3 of us at 1 will collect these sheets from each of your groups, and you'll probably be in groups of 5 or 6. And then we'll have a discussion, and you'll be able to benefit from talking with your colleagues that kind of share kind of some of the things that you're working on, and yet being able to hear the perspective, the concerns, the ideas of like management from different systems and PCCs from different systems.